This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Welcome to Psych Rounds, a resident-run educational psychiatry podcast. I'm Dr. Larry Wang, and I'm joined by my co-hosts, Dr. Tanner Hewitt and Dr. Bradley Miller. So today we're going to be taking a little break from the antipsychotic episodes and instead talk about sleep medicine with a focus in psychiatry. Our guest today is Dr. Barry Krakow, who completed his sleep medicine training at the University of New Mexico Sleep Center, as well as Stanford University. He is currently a board-certified sleep specialist practicing in Savannah, Georgia, and is trying to spearhead an initiative to implement sleep medicine education into psychiatry residency training programs. He's been involved with a Carlat Psychiatry Report, has a TED Talk on YouTube with around 750,000 views, and last year published a new book titled Life-Saving Sleep, New Horizons in Mental Health Treatment. Anything else you'd like to say to introduce yourself, Dr. Krakow?
That's a great introduction. Thank you very much, and thanks for having me on your program.
Yeah, as a first question to introduce how we think of sleep in the psychiatric lens, let's say you're a psychiatrist and a patient presents to your office complaining of depression, anxiety, and poor sleep. For the poor sleep specifically, what kind of questions should we be asking? What are you looking for? And should we be ordering any specific tests?
So the premise of the question brings us to this really critical area of knowledge gap that is rife throughout all of psychiatry, psychology, the mental health professions. And that is the singular point you said, poor sleep. What does that mean? If you think about the mental health profession and you think about the DSM, and not to, by the way, in any way discredit the DSM because it's got some very good information in it about sleep that virtually everybody doesn't read or doesn't practice. And so we'll come back to that in this discussion. But the premise of this case that you're bringing up is, what do people call that? Before you talk about diagnosing and treating it, what do you call it? So the average mental health provider, psychiatrist, psychologist will say, well, that's a sleep complaint. That's a sleep issue. That's a sleep condition. And that premise means that sleep issue is caused by the psychiatric problem. That's dead wrong over 90% of the time. And when I say the word dead, I'm not speaking with a term loosely. People are dying because the wrong conceptualization is being used to understand that phrase. It is not a sleep disturbance, a sleep complaint, a sleep issue, a sleep condition. It is a sleep disorder. And it's running and operating independently, co-occurring with the psychiatric condition, depression, PTSD, anxiety, and so forth. Again, now 80 to 90% of them, independent sleep disorder. That means if you choose the pathway of saying, this is a neurotransmitter problem, this is a secondary phenomena of a mental illness, and you start giving medications, that person will go misdiagnosed for 5, 10, 15, 20 years. So now you have to come back to, well, when the person says sleep quality, what am I supposed to be thinking? And the answer is very simple. They have a sleep disorder. And I've got to find out what that sleep disorder is. And the most remarkable thing about our research, it's been now in research publications going on 25 years, is that those sleep disorders are almost invariably a combination of psychological and physiological changes that are happening to the sleep that, yes, may be related and may co-occur with the mental illness, but they absolutely operate independently. And if you don't understand that, if you don't understand what that means, then you totally miss it. You miss a chance to radically enhance a patient's outcomes, because that sleep disorder operating independently is actually degrading the mental illness. And we've been preaching this, like I said, for more than 2 decades. We published the first big paper in JAMA in 2001. In JAMA, of all places, we published a randomized controlled trial showing that if you look at nightmares, chronic nightmares, as an independent sleep disorder, and I agree with all of you probably that nightmares could be a mental health disorder, no disagreement, but you can also look at it as a sleep disorder. We treated it with an innovative technique, a cognitive imagery technique known as imagery rehearsal therapy, randomized controlled trial of PTSD patients, female sexual assault survivors. Not only did their nightmares get better, but their PTSD got better. That's why I was accepted into JAMA. And how much better did it get? If you looked in the scientific literature in 2001, when our paper was published, you'll find several papers describing the use of Seroquel for the treatment of PTSD. So how large were their effect sizes with Seroquel? And how large were our effect sizes just treating their nightmares? Identical. So not a randomized controlled trial comparing IRT to Seroquel, but IRT study, Seroquel studies, same effect sizes, just by treating an independent sleep disorder without medication. You got PTSD to drop dramatically. So that's a good way to start this conversation, because most people in psychiatry, most people in mental health do not understand what I just said. They may intuitively say, oh, it makes perfect sense, but they have not found any way to take that information, digest it, absorb it, and apply it in their practices, because nobody is training them to think this way. So, Brad, going back to your first question, they wouldn't know how to ask the question to figure that out. They would just ask a bunch of questions and go, okay, well, what drug do I use for that? And that's a sad commentary on the field, but it is going on throughout these communities, and it's causing a great deal of suffering. And it is affecting morbidity, and it is affecting mortality.
Wow, well, I think that was a great way to start the conversation, Dr. Krakow. Kind of going along what you said, a lot of times when I'm working with patients who are struggling with depression and anxiety, people will tell me, oh, just treat the depression, treat the anxiety, give them some sertraline, and once they recover from the depression or anxiety, then their sleep will kind of just resolve on its own. But it sounds like you're saying something much different. Now, while I've got you here, I know you mentioned IRT, and we were talking about PTSD. So I was wondering if you could tell us more about this, because I believe that you actually developed image rehearsal therapy, I think in the 1980s or the 1990s. So can you kind of go into detail what it is, how you came up with the inspiration to kind of develop it, and, more along those lines?
Sure, but I want to make sure we segue back to the first part of your question. So Dr. Kellner and Dr. Neidhart, Robert Kellner and Joseph Neidhart, University of New Mexico School of Medicine, Department of Psychiatry, they developed IRT. I joined their team in the second year that they were working on the project, and then I took over the research just a couple years later for a variety of reasons. I was an internist. I wasn't even a sleep doctor yet. But I took over the research and did more of the studies on IRT. They did the original study published in the American Journal of Psychiatry. And this just segues from the fact that for over 100 years, people had put in case reports in the literature describing how you auto-suggest dreams to people, or if they auto-suggest it to themselves, it will treat their nightmares. It's that simple. And so we just refined the image rehearsal technique to say, select a nightmare, change the script of the nightmare, rehearse the script in your waking state, and that's it. When we completed the first set of research studies with Dr. Kellner and Neidhart, it was more or less random people with nightmares. So Dr. Kellner insisted we had to do one on PTSD patients. and he directed me to work with rape crisis centers in Albuquerque. And so I took the lead. Unfortunately, he passed in 1992. So I took over the helm and did that study. It started in 95. It got published in JAMA in 2001. And ever since, segueing back to your first part of the question, people have pointed to that study as we took a non-pharmacological treatment, we applied it to a sleep disorder, and we got mental illness to decrease. Why? Because we improved their sleep. And of course, we removed the distress factor of the nightmare. And so when you're sitting there, Larry, and you're thinking about this with your patient, and Brad, when you said about poor sleep, we want that to be extended to mean poor sleep quality. So if somebody says poor sleep, you immediately want to know, what does that mean? Because it almost always means poor sleep quality. You may find some younger patients who will say things like, oh, my quality of sleep is just fine. I could argue with them and probably prove them wrong 9 out of 10 times, but that's besides the point. Most people, when they come to you, they're thinking about, I want more sleep. Some of them are smart enough to say, I want better sleep. Anybody who wants better sleep is actually more insightful to the problem. Because what you're dealing with is a major, major issue with sleep quality. And when I said earlier that people have psychological and physiological problems, I'm talking about both as it relates to sleep quality. So when you're in an interview, and I'm teaching this to the Gateway Behavioral Health Program here in Savannah. They have a psychiatry residency training program here. It's about 6 years old. I've started with them 2 years ago. And we're showing them how asking the questions about sleep quality brings to the forefront what's really going on. And we'll go into some of the specifics of that, in this program, so you can see some surprising eye-openers as to well, how do you know if somebody's got good sleep quality? I mean, is the patient supposed to know that? Is the doctor supposed to help them tease it apart? And if you don't get this training, and I'm going to presume, and please tell me if it's otherwise, most people don't get trained in sleep medicine in medical school, and they don't get training in psychiatry. They don't get training in internal medicine and family medicine. So they're thinking, well, poor sleep quality, what does that mean? You don't feel good when you wake up? Well, by the way, that's a great question. If you don't feel good when you wake up, you got about a 99.9% chance there's something wrong with your sleep quality physiologically.
Yeah, that's super interesting. And I want to ask more about specific factors of sleep. So obviously, I feel like as clinicians, you mentioned sleep quality. I feel like we focus a lot on sleep quantity. So how many hours a night patients are getting. But we're not really looking at those other parameters, like you said, including the sleep architecture, fragmentation, disordered breathing. I've personally heard and looked into sleep inertia and how that could be disrupted in affective disorders, and I find that very interesting. I was wondering if you maybe now we can delve deeper a little bit, and we could you could educate us and our listeners into some of the clinical pearls in these domains. Particularly, I know disordered breathing. I know you've done a lot of work with.
Right. Well, let's start with the general framework of, does anybody in mental health understand what sleep is? I'm not trying to be antagonistic, but I'm asking, does anybody really understand that it's your brain? Everybody knows what a lymphatic system is. The G, glymphatic, is the G for glial cells. So the glymphatic system is the lymph system in your brain that does what? It removes toxic waste material from your brain. You'll never guess when it's most operational. Go ahead, just try and guess.
I'm going to venture out and say during sleep.
Wow, this guy's got it. Okay, but now here's the big part. What type of sleep? And before you answer, think about what we've been talking about and see if you come up with the right answer. You got 3 guesses here,
I'm going to go with REM sleep.
No.
I'm gonna guess deep and REM.
Deep, yes, but there's still a better way to say it than just deep. Tanner, it's all on you now. We've been talking about sleep. We've been talking about sleep quality.
See, I was going to go with deep REM also, but if you're looking for more delineation in maybe like N1, N2, or N3, maybe like the N3.
N3. We're all talking the same page. N3. But what about N3? Is it fragmented N3, or is it super high quality N3? In other words, just because you go into N3 doesn't mean that sleep can't be fragmented by whatever. It could be fragmented by PTSD, hyperarousal, could be fragmented by depression, could be fragmented by sleep disorder breathing, by leg jerks. But if you don't have any of those things, then you have unfragmented, well-consolidated delta sleep. And that's going to prove to be the most operational place where the glymphatic system is operating. So all the people you're treating, and I always love to say it this way, when you go into clinic this week and you treat somebody who's sitting across from you and you're talking to them, you want to have X-ray vision where you're going to look in their brain and you're going to go, holy cow, look at their brain waves. They're all screwed up. And that's just not neurotransmitters. That's their sleep brain waves are all screwed up. And you say, well, can you see that while they're awake? I don't think so, although there's researchers that are trying to do that, but you could certainly see it while they're sleeping. And so the heart of the matter of sleep quality is when you ask somebody a bunch of questions, you're trying to figure out if their sleep is fragmented. And you might think, well, does he mean like, okay, well, they wake up at 2 o'clock in the morning, can't get back to sleep? Well, sure, that's fragmentation, right? Something woke you up. You were up for 5 minutes or an hour. So that means that sleep was fragmented, but that's not what we're talking about. If a person has sleep disordered breathing as a single best example, how many times a night are they having an arousal? Which an arousal, by the way, in sleep medicine is a short awakening. Could be 10 seconds, 15 seconds. Awakenings are allegedly 16 seconds. Most people don't know, how many times they wake up. Sleep disordered breathing, how many do you think? What's your guess? Do you know?
I'm going to guess 20.
I'll guess 50. I'll be a little more aggressive than Brad here.
Okay.
I'm going to go right in the middle at 35.
This is great because you all have no training whatsoever in sleep that you would give those answers. You gave exactly the same answers as patients who come in to see us at sleep centers. And these are the patients who are a little bit more insightful. We go, well, how many times you wake up at night? And they go, I don't know, maybe 8 or 10. I say, well, what about the fact that you may not know about all these awakenings? They go, okay, all right, 20, 30. So what do I say? Put a 0 at the end of your number. 350, 500, 200. So people with sleep disordered breathing are having arousals hundreds of times per night. Did any of you know that?
No, not at all.
Okay, so that's what's happening to the patient you're sitting across from, and this is my point. If you sit there, and instead of you saying the words, "Gosh, this person looks really depressed," I want to key in on the emotional states here because they look depressed. Okay, that's fair. This person looks really wired. Could be some PTSD hyperarousal, but I'm going to give you one more. Look at their face and ask if they look tired. Ask if they look sleepy, because that's what they're suffering from. The ones who have the most complex sleep disorders are the people you're going to start to look at and you say, this isn't just looking psychiatric. There's something else physiological making their face look this way. And I'll come back in a moment to who those people are so you'll know specifically where to look. But this is a fatigued look in the face. Some of them sometimes can't even keep their eyes open because they get sleepy. In psychiatry, you don't see as much of that as we do in sleep medicine. You see much more fatigue, tired faces, which explains why it's so hard to pick this up. Because when people are sleepy, it's much easier to snap and go, wait, why is this guy sleepy? Okay, maybe they didn't get enough sleep. That's reasonable. But what's the single biggest cause of somebody being sleepy during the day? Is it not getting enough sleep, or is it poor quality of sleep?
So based on what you're saying, Dr. Krakow, it seems like we're really underdiagnosing sleep apnea in a lot of our patients. I think maybe part of it is because we stereotype these patients as being older, obese males as kind of the classic population. But like reading some of your work, that's not the cause of sleep apnea. It's only something that might worsen underlying sleep apnea. So I was wondering if you could talk about that a little bit more, but also why sleep apnea could cause nocturia or increased urination at night.
Sure. So sleep apnea is a condition of your upper airway. Unfortunately, even in primary care, you will have these stories. You will have these stories even in sleep centers. Somebody walks into a sleep center, a psychiatric patient. They're on sleeping pills. They suffer from insomnia. They're not overweight. They're not sleepy. You know what the sleep doctor says to them? Why are you here? What is it you think I'm going to do for you? And the patient says, well, a doctor tried to treat me and they didn't have any luck. They wondered if you had some ideas. And I actually can recount stories of people being told, go away. I can't help you. You're a psychiatric patient. There's a psychiatric problem. We don't do sleep tests in you. So that's mass ignorance on the part of people in the mental health professions and also in primary care. It is the human airway. You look in somebody's nose. You look in their hard palate to see if it's elevated. You look at their facial structure. If you notice, my facial structure, although it's not going to show up on the podcast, is vertically shaped. A vertically shaped head is a very high rate of a narrowed airway beginning by the age of 2. So my sleep disordered breathing probably began when I was 2. And I have evidence for this because my mother had a very difficult time getting me to settle when I was a child to sleep. And so people think, well, isn't that nervousness? Isn't that insomnia? Isn't that bad parenting? Isn't that something else? Well, could be any of those, but it could also be an underlying intrinsic physiological problem with breathing. And when you don't breathe, you'll never believe this, but when you don't breathe, you really don't like to sleep. You really don't like to be asleep when your unconscious mind knows you're not going to breathe. So this is so important in understanding that it's the airway, and then that means any doctor can look at a patient differently and go, well, let me look at your airway. Let me look at your throat. Let me look at the crowding. One of the most obvious things you do is you say, open your mouth and stick out your tongue. And then you say, don't say ah. Don't lift the palate in the back. Just stick out your tongue and let me look. So did you learn in medical school the Malampati criteria of anesthesiology? And that's a measure of crowding. If you have somebody stick their tongue out and you can't see the airway, that's a crowded airway. If you've got somebody who's younger and has enlarged tonsils, that's a crowded airway. If you've got somebody who has a huge arched palate pushing up into the floor of the nose that's blocking air from getting through the nose, again, another marker. So all these things can be learned, but the point is that it's not enough to ask somebody, do you snore? Because snoring has little to do with sleep apnea. Did you all know that?
No, I mean, I think the main thing that comes to mind is the stop bang sort of criteria I learned in family medicine.
Yeah, that's a useless tool in the field of psychiatry. In our Mayo Clinic proceedings paper, we took some of those scales and compared it to our scale. Our scale is just, it's in that paper. It's just a series of questions asking people, do you wake up with a headache? Do you wake up with a dry mouth? Do you go to the bathroom at night, the nocturia that we'll talk about next? Do you have unrefreshing sleep? Do you get tired and sleepy during the day? These things are more important than breathing because breathing is occurring at night and you need an eyewitness. That's very difficult. We published a paper 15 years ago showing that trips to the bathroom at night could be as predictive and possibly more predictive of a sleep breathing disorder than snoring. So how could that be? Because when you have sleep apnea, you're struggling to breathe and you put all this incredible pressure in your intrathoracic cavity. Just imagine yourself choking. You're struggling like mad to pull air in by producing all that extra pressure in your chest cavity. It forces the venous return back into the right atrium at a higher frequency or flow than is normal. Your right atrium, which has sensors in it, mistakenly thinks it's fluid overloaded. Because in the mind of the right atrium, you are fluid overloaded. The right atrium then releases atrial, not beta, but atrial natriuretic peptide, goes to the kidneys, you make more urine, and you wake up at night to pee. Most people think in primary care and even in urology and in sleep medicine that waking up at night once or twice a night to use the bathroom is normal. And because so many people do wake up at night to use the bathroom, it is technically a normal by the concept of normal being what do most people do? So how do you explain normal when we put somebody on a certain type of PAP machine to treat their sleep disordered breathing, different than CPAP, by the way, and their trip to the bathroom goes to zero? Zero. More than half the people, it goes to zero. And these people are astonished. Like, you got to be kidding me. Like, wait a second. I've been to all these doctors. They said it was the prostate. They said it was the bladder. They said I was getting older. And there are other reasons. You could drink too much water. You could. Many people who are on a PAP machine can drink 32 ounces of water within 1 hour of going to sleep and not wake up and pee. That's how powerful this is. And so if that isn't known and people keep thinking, well, 1 and 2 is normal, again, you have a place where people will then say, well, I don't know what this guy's talking about because everybody wakes up to pee. Why should it be zero? Okay, well, that's fine. You can think that. But would you like your trips to the bathroom to be cut down to zero? And you know what? Somebody who's got insomnia would love to not wake up at night to pee.
I think we're just so shocked by a lot of what you're saying because it's very different than a lot of the other ways that we approach sleep in psychiatry, which is really oversimplistic. Like right now, a lot of the times we'll just be like, oh, how many hours do you sleep at night? Only 5 or 6. That's not very much. Are you feeling tired? Yes. Let's start trazodone 50 milligrams at night. And then maybe we'll do a stop bang questionnaire. Like Dr. Miller said, maybe we'll refer the patient to a sleep specialist, but that's a lot of what we do. It's very basic compared to a lot of the concepts that you're explaining right now.
Right. And it's, we struggle with this over at Gateway. We're trying to develop a system and figure out a way to, broaden this. And there is a bridge. And I wrote in my book, Life Saving Sleep, I've written about the bridge in great detail, which is early conservative treatment of sleep disordered breathing actually produces more bang for the buck in terms of actually getting over the hurdles. In other words, most people, and you're going to discover this now that you realize this possibility, that lots and lots of your patients have nasal issues. And I don't know if you know this from medical school, but most people normalize nasal breathing. Most people do not pay attention to whether they even mouth breathe. You can meet people all the time and you ask them, do you mouth breathe? Most people have one of two conditions, and often both in psychiatry and in sleep. You all have heard of allergic rhinitis, hay fever. Have you heard of non-allergic rhinitis? It's very common in psychiatric patients. Anxiety, been written about in the 19th century. Anxiety can actually cause a stuffy nose. So there are treatments now on the market for both allergic and non-allergic rhinitis. There's also simple treatments just to clear out the nose. Let me give you an example. Let's suppose you see a patient this week and you're now suspicious they could have sleep disorder breathing. And you're saying, well, what do I do with this? You then go down the pathway of saying, do you have a runny nose, a congested nose, or a stuffy nose? Some of them will go, I'm not sure. Some will say, yeah, I have it. And you go, well, what about when you wake up? Like, do you have to blow your nose? And some will say, oh, yeah, I do. What about in the middle of the night? Oh, yeah, sometimes I do. All these things are abnormal. The nose is supposed to work perfectly. You're supposed to be able to breathe through your nose and hear nothing but what?
Ideally nothing, yeah.
Air.
Air. Yeah, nothing or air. Okay? And you can do that with your patient. You can say, let me listen to you breathe. And as you develop the habit, you go, oh, you know what? That doesn't sound like just air. And if you ever did an ENT rotation and learned about what's called inspissated mucus of the upper airway, you know that a person can develop dried up mucus in their passages over a long period of time and have no awareness of it. And only once they start doing regular, like saline rinses for several days or several weeks, then goobers will start coming up. They'll start blowing their nose and they'll go, wow, I can breathe differently now. So what I'm getting at is learning all the ins and outs of nasal hygiene and applying it to your patient. You can actually see results when they come back and see you on the next appointment. It could be a week later, 2 weeks, or 4 weeks. And so the next part of it is the ones who are the most interested, the ones you can convince. Because again, like you're saying, this isn't just new to you. This is new to your patients. They're going, well, why are we talking about this? And you're saying, because we've learned some very interesting information that might be relevant to your care. And since you have shown to me with some questions and by listening to your nasal breathing, you've got a stuffy nose, you've got a congested nose, etc. Start using nasal strips or nasal dilators. And psychiatric patients have difficulties with these things. It's not a slam dunk. It takes some time. It might be they come back the next appointment. You go, oh, well, I tried it once. I couldn't do it. Say, okay, well, show me what you did. Show me how you tried it. Most people, unfortunately, have to use these devices for several weeks to get a response. But let me play it out for you the way you're hoping to see it. For yourselves, once you experience this either personally, like you say, well, I'm just going to try this for myself, or a family member, or one or two patients that are just, higher functioning, and you know that they're going to understand the instructions and, they're going to relate. They're going to come back to you and they're going to go, this is really weird. Like those nasal strips, I really am sleeping better. I mean, does that mean I have a sleep breathing condition? I mean, what's going on? Why would something that simple make me sleep better? And why didn't my primary care doctor ever ask me about this? Once you experience that with patients, which has happened to me, we did studies on nasal strips, by the way. We published the only randomized controlled trial in the scientific literature showing the treatment of insomnia in people who didn't know they had sleep-disordered breathing, but we knew they had it. Because presumptively, we asked them the right questions and we knew they had to have it. They didn't think they had it. We said, we want you to use nasal strips. 75% of them got a clinically clear improvement in insomnia in 4 weeks. And the control group, which got nothing, just education, had no change. So nasal strips work, but you have to know how to use them. You have to be, diligent about using it. So all these steps, nasal saline, nasal strips, nasal dialers. And then the nasal sprays are fascinating because I have a free video on my website, barrykrakowmd.com, and it's called The Nose, NOSEKNOWS, The Nose. In that 1 hour video, I go over non-allergic and allergic rhinitis and the different nasal sprays. So in medical school, you may have heard about antihistamine nasal sprays, anticholinergic nasal sprays, steroid nasal sprays. You may even have heard about the xylitol nasal sprays. These nasal sprays are amazing and far better than most of the medications that people use for their problems with allergies, congestion, or non-allergic rhinitis. If you build just a little repertoire of these, interventions, you can actually start working with your patients very, very regularly so that when they come back to you 4 and 8 weeks later or 12 weeks later, they're the ones saying to you, this is really interesting. I am sleeping better. Do you think I should get a sleep study? You got them. They now know there's something physiologically wrong with their sleep caused by their breathing, and you have actually helped them to see that by using an early conservative treatment step instead of saying, oh, here's a CPAP machine, and then they go like this because, get me out of here. CPAP is very, very difficult to use, very difficult.
So, Dr. Krakow, talking about air and structure and all of these things, what are the other interventions that we should have on our radar as a psychiatrist, right? Because I hear these new implants, things like Inspire. I hear people being on BiPAP, CPAP, APAP. What should we have on our list of kind of the equipment know-how as we interact with our patients?
Right. So let me see if I make these 2 points first, and then we'll come back to all the other innovations. I love Inspire because it's based on one of the greatest marketing campaigns ever handed to somebody. They knew that CPAP sucks. And those people are so smart that all they had to do is get people on the radio saying, oh, I hated my CPAP. I hate it. And you know what? It related to 2 out of every 3 people that ever tried CPAP. Unfortunately, Inspire is not where we all want to see it. It does help some people, but it is not a super effective treatment. You can always argue they threw away their CPAP machine. Now they're doing Inspire. At least they're getting treatment. It's the same argument the surgeons use. Okay, well, we cut some stuff out. Now their AHI, apnea-hypopnea index is better, and so forth. The other point I want to make is that we stopped using CPAP in 2005. CPAP is not a good choice in psychiatric patients because psychiatric patients tend to have larger, greater degrees of anxiety than the general population. CPAP is one air pressure. When you breathe in and breathe out, it's the same pressure. It's extremely difficult to breathe out against CPAP. We discovered this in 2005 because our sleep center specialized in the treatment of mental health patients with sleep disorders. So we saw thousands of people with depression, PTSD, anxiety, panic attacks, claustrophobia, schizophrenia, bipolar, with sleep apnea. And they hated CPAP. So in 2005, we switched them all to bilevel. So from 2005 on, we began using bilevel, auto bilevel, ASV, which is a more advanced version of bilevel. And so this is a very difficult point to get across because you would want somebody to get a sleep study, but the doctors you're going to deal with are going to want to put your patient on CPAP. And you're going to want to try to negotiate with that doctor and say, my patient has a lot of anxiety. I don't think I want them on CPAP. I'd like you to try them on bilevel. Are you willing to do that? And the answer most of the time will be no, thank you. They'll say, well, the patient's insurance is going to make him try CPAP. And then if you want to get really nasty, you say, okay, that's fine. You prescribe them CPAP. I'm going to tell them to go home, try the CPAP one time. If they don't like it, I'm going to tell them to put it in their closet for 90 days. Then I'm going to tell them to come back and talk to you and say, I tried CPAP, I couldn't use it. Now you prescribe me bilevel. And if you think that doesn't happen, it does. People on the ground level in the trenches are absolutely, what's the word that goes beyond anger? They're enraged by the care they're receiving at sleep centers when doctors do not tell them there's something else they could try besides CPAP. They're just enraged because they've read about our work and other people's work showing that bilevel is more comfortable. So anyway, keep that in mind. One of the most important ones you want to hear about for innovation is not Inspire for these people, because that's got so many other little intricacies that now you're asking for somatosensory amplification. I don't know if you learned that way in psychiatry. Maybe you've heard the term attention amplification, that if you get a symptom and you keep focusing on the symptom then obviously becomes worse. It doesn't get better. That's what people do with CPAP. That's what people would do with something like Inspire. So it's a very difficult pathway for them. One of the greatest pathways is called oral appliance therapy, where they can put a dental device in that thrusts the jaw forward, which the lower jaw, which then makes the airway larger. And you can get anywhere from a 50 to 90% improvement in sleep disordered breathing. I started my treatment in 1998 with one of those, and it was so good that for the first time in 38 years, because I was around 50 at the time, first time in 38 years, I did not have a desire to nap during the daytime. So for 38 years, I either did nap every day or wanted to nap every day. And then I used this device, and within a week, the quality of sleep I had was like nothing I'd experienced in my life, because I could only remember my sleep from teenage years, maybe something in childhood. But in childhood, like I said, my mother said I was a poor sleeper. There is another device out there called Excite OSA, very interesting, based on the model of if you put an electrical stimulator in the mouth for 20 minutes a day for about 6 weeks, it may strengthen the tongue, and in doing so, it may reduce the sleep breathing events by as much as 50%. That's a big deal. Again, all these things are, patient specific. And the great news about sleep apnea is the failure of CPAP and the fact that sleep centers are not embracing these advanced PAP machines like we do, bilevel ASV. All the entrepreneurs are going out trying to find another way to treat sleep apnea. And sooner or later, they're going to be coming up with models that really do make a big difference.
One follow-up question I have for that, Dr. Krakow, is we talk about patients being unaware of some of the treatment options. One of the things I find is that patients sometimes are unaware of how sleep studies actually operate, and that there's at-home sleep studies now versus in-lab sleep studies. And as psychiatrists, if we make a referral for a sleep study for our patient, what is the level of satisfaction we should have with an in-home versus an in-lab sleep study? Should we be opting for one over the other for our patients?
That's a great and really complicated question, which is covered in part, in my new book, Life-Saving Sleep, because the question first starts with the patient saying, well, do I do this sleep study on my medications, or do I have to get off the medications? And most sleep centers will want them to have the person on the medication, because they'll say, well, that's what your natural environment is right now, whether it's in the lab or at home. The problem with the sleep center environment now is that the doctors are all but forced into home testing. So the chances of you getting an in-lab study has to do more with what you know about that patient. You might discover starting with a home study is better because it's less invasive. They're in their own home. There's only so many wires. It's an easier procedure. The laboratory is very intimidating to a lot of patients. But nonetheless, you're asking the more important question of, did you know that home sleep studies, we need a drum roll right now, home sleep studies don't measure sleep. Home sleep studies measure breathing, oxygen, heart rate. So let's say you wanted to know whether somebody's got sleep disordered breathing, and you know that your patient is anxious. You go, well, come on, let's just get a home sleep study. That's a reasonable option with one major caveat, and that is the range of sleep disordered breathing in the scientific literature is well described and largely ignored by most sleep centers. Most sleep centers go by something called the apnea-hypopnea index, and apnea is 100% stoppage of breathing. Hypopnea is a 50% stoppage or reduction in breathing. And so because insurance pushes this, there is this forced marriage between sleep centers and insurance companies to just pay attention to the apnea-hypopnea index. And the patients suffer because there's a third breathing event. I had the great fortune to learn about it by training with Dr. Christian Guilleminault at Stanford in 1993. And this breathing event is more subtle. It's more difficult to detect, but it's quite powerful. And I'll give you an example in just a moment. Basically, it's a 25% reduction in breathing. It still causes arousal activity, but many home sleep testing monitors don't look for it. Or even if they do look for it, the doctor who reads the study either ignores the data or is not impressed by the data. But let me think about it this way. I've just told you there are 3 breathing events. Apneas sound really bad. You stop breathing. Hypopneas, you lose 50% of your breath. Gee, that sounds pretty bad. Okay. Upper airway resistance, also called flow limitation. You lose anywhere from 10 to 25% of your breath. You're smart people. You go, that doesn't sound good. I wouldn't want to be choking and losing 25% of my breath. Well, guess what? Let's say you come to the sleep lab and you have 0 apneas, 0 hypopneas. All you've got is this flow limitation problem. This little itty bitty flow limitation problem of a 25% reduction in breathing, and that's all we can find. And nobody ever treats it because they go, well, that's nothing. Guess what you're going to have a chance of getting in the next 10 years? Insomnia, fibromyalgia, high blood pressure, nocturia, morning headaches, depression, anxiety. In other words, with no apneas or hypopneas, you're getting all of the same kinds of sleep problems that psychiatric patients complain about. All because of this little itty bitty breathing event that these other doctors ignore. And this has been a problem in the field of sleep medicine since the 1980s, when Dr. Guilleminault discovered this in children, then again in the 90s when he discovered it in adults. And to this day, there's only about 1 out of 3 or 1 out of 4 sleep doctors that pays attention to it. And so what I'm getting at is, home sleep study is good, but if it comes back negative, what are you going to tell them if they have insomnia, they're failing hypnotics, they wake up at night to pee, they have a headache in the morning, they have a dry mouth in the morning. Oh, and by the way, they do snore. Oh, and they also don't feel good when they wake up in the morning, and they're tired and sleepy during the day. Are you going to say to them, oh, I guess you don't have it? No, you're going to have to learn to say, I wonder if that test is a false negative. Let me explain to you what a false negative is, and let's tell that sleep doctor he needs to bring you into your sleep lab, into their sleep lab, and now test you with all the sensors and take a closer look for subtle breathing events.
So one of my other questions for you, Dr. Krakow, is where do our medications fit into the sleep-related disorder spectrum? You know, we have a lot of options out there, such as trazodone, Seroquel, the Z drugs, and even some therapies such as CBTI. And there's some data out that medications like trazodone, for example, are not that effective over time. So I just wanted to hear some of your thoughts on where you think medication fits into the equation.
So I delve into this obviously a lot in life-saving sleep, but not the way you're asking it, because I'm not at all anti-drug. Absolutely, there are people who need these drugs at this stage in civilization where we have this primitive approach to treating sleep problems because we didn't know any better. The field of sleep medicine is really new, so how could people know? The largest majority of the people you deal with do not need sleeping pills. But that doesn't mean you can snap your fingers and make that whole construct go away. You can't. So really, I say you're going to learn from people at your residency training program who have very good experience using the drugs you've just described. And they're going to tell you, this is how we've done it. This is why. This is the research basis. And they are, relatively speaking, correct. And so you follow that pattern. It was funny that you said trazodone may not be effective long-term because nearly all those drugs are not effective long-term. You don't find lots of people who use these things long-term. The average person uses this drug a period of time and says it doesn't work anymore, or it never worked. There are cases where you hear of success, and that's great, because if it works for them and it's helping them, you know you're helping their mental health because they're sleeping through the night, they're getting good quality sleep. So this brings us to the question of, when will psychiatry residents want to learn why somebody got down this pathway thinking the focus would be a medication, when really it's just a few questions you have to ask the person to begin the long trek, because it's a long trek when somebody's been on these drugs. It takes me between 1 to 2 years to get somebody off of these drugs when they come to me and they start talking about, what else can I do? Well, I've got to first explain to them, did anybody explain that you really have sleep apnea? They go, no. Well, that's causing all the arousals. That's causing all the awakenings. Let's treat that first. And if they're a psychiatric patient, it could take them 6 months to get used to a PAP machine or even a dental device. I don't want them touching their medication. They stay with the medication while they're working to enhance their sleep quality. So, CBTI comes into play only when you have reasonably functioning individuals with an intellect that wants to hear new information. They've got to be thirsty for new information. And the two most important ones you need to hear for a session like this is the concept of, if you recognize somebody has what some people call sleep anxiety, but what I have written about for years in my books and papers, losing sleep over losing sleep, that symptom is actually a red flag for suicidal ideation. So if a person has an obsession about sleep, where you might just call it sleep anxiety, I call it losing sleep over losing sleep. They're thinking all day long about their sleep. What am I going to do about it? How am I going to solve it? That person is not a candidate to get off of drugs unless they're in the hands of a really expert sleep doctor who not only understands CBTI, but understands emotion-focused therapy and explains to the individual what's actually going on in this obsession that's driving them crazy.
So, Dr. Krakow, as we're kind of drawing to a close here, how can we psychiatry residents learn more about sleep medicine and get more adequate training in sleep medicine? I mean, you can obviously do a sleep medicine fellowship, but that's a pretty big investment. Are there any other ways that we can be more competent in treating sleep disorders in our patients? That's question one. Number two, any thoughts about coming to Michigan to help us out with our residency program? I know it's a little bit cold during the winter, but the rest of the year is quite nice, actually.
Well, number two is actually the easiest way. In other words, what we do now here at Gateway is we do a series of didactics that help people. But where the proof is in the pudding and where you'll have the most fun is to operate something like a sleep clinic. But what that really means is that, let's say you did have me come out for a day or a week, whatever, and you're bringing patients into clinic who you know are really hardcore insomniacs, and they've failed multiple medications. And you're looking at it, say, okay, well, what do we do? Well, let's have this patient be here and work with Dr. Krakow, and let's see how he goes through those steps. So that's a very big way to do that. In fact, I was just in Israel doing training of many of the mental health professionals there, because as you can imagine, everybody's got PTSD in Israel. And I said to them, what do you want to focus on? You'll love this story, because I knew what was going to happen, but they didn't. They said, well, they contacted me because everybody's got nightmares in Israel. How could they not? So I'm a known expert in nightmares. Would you come to Israel and train our professionals on nightmare treatment? I said, sure, absolutely. But by the way, people with PTSD have more complexity to their sleep problems. Would you like some additional training in that too? So they said, sure. So I do some training with them. I do some didactics. And then they bring 3 patients to see me in front of their therapists.
So, Dr. Krakow, if any of our listeners want to know more about you, your work, how can they do so? And also, how can they find your most recent book, Life-Saving Sleep, New Horizons in Mental Health Treatment?
Wherever books are sold. It's on Amazon, of course, and everywhere else. My main website is barrykrakowmd.com. And on that website, there are plenty of free resources, videos. There's also more books and videos that are for sale that may be relevant, especially a number of things on nightmare treatment I have on there. I also have a sleep health coaching service. And I developed this for the reason that there are many people with very complex insomnia, sleep apnea combination problems that just are not getting the care they need. And so instead of my treating them, they come to me and we work through the dialogue of all they've been through to understand why it didn't work. And then we build a new set of narratives for them to understand what they can do to go back and communicate with their sleep doctors and psychiatrists and primary care doctors to get better care and a better response. And of course, I certainly recommend that they, get a copy of the book. But the coaching sessions have gone very well. And I've been surprised how popular they are. But I guess that's a sad commentary that many people, need that service. I also have a free newsletter on Substack. It's called fastasleep.substack.com. And I publish on that about 3 or 4 times a month, sometimes talking about research findings, sometimes putting on the podcasts that I do, sometimes putting news updates.
Well, thank you very much, Dr. Krakow, for coming on the podcast. It is greatly appreciated to have one of the leading experts in the field take some time out of their day and come on to this podcast.
Great talking with you. I hope we get a chance to work together. That would be a lot of fun.
Absolutely. Thank you to our listeners for tuning into this week's episode of Psych Rounds. As always, feel free to like, rate, or comment our show as it helps us reach a larger audience. We want to again extend another thank you to Dr. Krakow for coming on the show and introducing us to some of the concepts around sleep medicine.